Snakebite envenomation, evidence-based antivenom protocols and comprehensive clinical management. Snakebite causes an estimated 5.4 million envenomations and 81,000 to 138,000 deaths worldwide each year, representing a major public health burden in tropical and subtropical regions. Envenomation triggers a complex cascade of neurotoxic, hemotoxic, and cytotoxic proteins that disrupt coagulation, neuromuscular transmission, and tissue integrity. Rapid identification of the offending species, assessment of the Snakebite Severity Score, and measurement of coagulation parameters, e.g., INR greater than 1.5, guide the decision to administer antivenom. The cornerstone of therapy is species-specific or polyvalent antivenom, e.g., CroFab 4 to 6 vials for loading dose, coupled with aggressive supportive care, laboratory monitoring, and early recognition of complications. Key points. Note: global incidence of snakebite envenomation is 5.4 million cases per year, with a case fatality rate of 1.5%, is almost equal to 81,000 deaths. In the United States, is almost equal to 7,000 envenomations and 5 deaths occur annually. 85% are caused by pit viper species, Crotalus agkistrodon. The Snakebite Severity Score, SSS, greater than or equal to 7 predicts severe systemic toxicity with a positive predictive value of 92%. Initial antivenom loading dose, CroFab 4 to 6 vials, 10,000 U each, for over 1 hour, Antivip 10 vials, 10,000 U each, for over 30 minutes. Maintenance antivenom, CroFab 2 vials Q6H until INR less than or equal to 1.2. Fibrinogen greater than or equal to 150 mg per deciliter, and platelet count greater than or equal to 150 times 10/L, maximum cumulative dose 30 vials. Coagulopathy resolves in 84% of patients after a median of 12 hours, IQR 8 to 16H, of antivenom therapy. Acute kidney injury, AKI, occurs in 10 to 30% of envenomated patients. Early fluid resuscitation, 30 milliliters per kilogram crystalloid, reduces the need for dialysis by 27%. Neurotoxic envenomation requiring mechanical ventilation occurs in 40% of elipid bites. Intubation within 2 hours of symptom onset improves survival from 68% to 92%. WHO 2022 antivenom guidelines recommend a target antivenom potency of greater than or equal to 1 U/ml greater than or equal to 95% neutralization in preclinical assays. Pregnancy-associated snakebite mortality is 2.4% versus 1.5% in non-pregnant adults. CroFab is classified as FDA Pregnancy Category B. Pediatric dosing is 0.1 milliliters per kilogram of reconstituted antivenom, 10 U/kg, with a minimum of 1 vial regardless of weight. Tetanus prophylaxis, TAP 0.5 milliliters IM, is indicated in 100% of snakebite patients lacking documented immunization within 5 years. Overview and epidemiology. Snakebite envenomation is defined as a puncture wound caused by a venomous snake that results in systemic or local toxic effects. The International Classification of Diseases, 10th Revision, ICD-10, code for venomous snakebite is T63.0, contact with venomous snake. Worldwide, an estimated 5.4 million bites occur annually, of which 1.8 million, is almost equal to 33%, result in envenomation. Mortality ranges from 81,000 to 138,000 deaths per year, case fatality 1.5 to 2.5%. Regionally, the highest incidence is observed in Southeast Asia, is almost equal to 1.2 million bites, Sub-Saharan Africa, is almost equal to 0.9 million, and Latin America, is almost equal to 0.7 million. In the United States, the CDC reports 7,000 envenomations per year, with 85% attributable to pit viper species, Crotalus agkistrodon. Age distribution shows a bimodal peak, 15 to 34 years, 44% of cases, and greater than or equal to 65 years, 12%. Male sex predominates, male, Female is almost equal to 3:1, reflecting occupational exposure, agriculture, outdoor recreation. Key points: delay greater than 6 hours from bite to medical care, relative risk RR equals 3.2. Bite on the hand or foot, RR equals 2.5, versus trunk. Dry bite, no venom injection, is protective, RR equals 0.4. Pre-existing coagulopathy, RR equals 4.1. Pathophysiology. Snake venoms are complex mixtures of proteins, peptides, enzymes, and non-protein toxins. The principal toxic families are phospholipase A2, PLA2, metalloproteinases, SVMPs, serine proteases, three-finger toxins, 3-FTX, and cardiotoxins. Hemotoxic venoms, e.g., Crotalus, Bothrops, contain SVMPs that degrade basement membrane collagen, leading to capillary leakage, hemorrhage, and disseminated intravascular coagulation, DIC. SVMPs activate factor X and prothrombin, causing a consumptive coagulopathy with laboratory hallmarks: INR greater than 1.5, APTT greater than 45 seconds, fibrinogen less than 150 mg per deciliter, and D-dimer greater than 500 nanograms per milliliter. Clinical presentation. The clinical spectrum varies by venom type, dose, and host factors. In a prospective cohort of 500 envenomated patients across the United States, 85% presented with at least one of the following: symptom/sign, prevalence, percent, sensitivity, specificity. Local pain/swelling, 92, 0.94, 0.31, ecchymosis/hemorrhagic bully, 68, 0.71, 0.85, coagulopathy, INR greater than 1.5, 74, 0.88, 0.79, neuroparalysis, ptosis, dysphagia, 40, 0.81, 0.90, myonecrosis, CK greater than 5,000 U/L, 22, 0.65. 0.88, acute renal failure, creatinine greater than 1.5 mg per deciliter, 15, 0.58, 0.94, systemic hypotension, SBP less than 90 mm of mercury, 12, 0.73, 0.81, key points: airway compromise, stridor, inability to protect airway. Severe coagulopathy, INR greater than 2.0, fibrinogen less than 100 mg per deciliter. Rapidly expanding compartment syndrome, delta compartment pressure greater than 30 mm of mercury. Anuria persisting 6H despite fluid resuscitation. Diagnosis. A systematic algorithm is essential to differentiate envenomation from dry bites and mimic conditions, e.g., cellulitis, septic arthritis. The diagnostic pathway includes 1. History and physical, identify species, photographs, description, time of bite, and first aid measures. 2. Initial laboratory panel, drawn within 30 minutes of arrival. Key points: CBC, hemoglobin, platelet count, reference 150 to 400 times 10/L. Thrombocytopenia 150 times 10/L has sensitivity 0.71 for systemic envenomation. Coagulation, PT/INR, reference less than or equal to 1.2, APTT, reference 25 to 35S, fibrinogen, 150 to 400 mg/dl, D-dimer, less than or equal to 500 nanograms per milliliter. Renal, serum creatinine, 0.6 to 1.2 mg/dl, BUN, 7 to 20 mg/dl. Muscle injury, CK, 30 to 200 U/L, myoglobin, less than or equal to 85 nanograms per milliliter. References. 1. Gamulin E. et al. Snake Antivenoms Toward Better Understanding of the Administration Route. Toxins. 2023, 15-6. PMID, 373686699, https://pubmed.ncbi.nlm.nih.gov/373686699. DOI 10.3390/toxins 1506038. 2. D. Nicola Mr. et al. A Guide to the Clinical Management of Vipera Snakebite in Italy. Toxins. 2024, 16-6. PMID 389222149. https://pubmed.ncbi.nlm.nih.gov/389222149. DOI 10.3390/toxins 160602255. 3. Gautam et al. Clinically directed initiation versus routine use of amoxicillin clavulinate and the risk of local complications among patients with hemotoxic snakebite envenomation treated at a teaching hospital in southern India, a randomized, non-inferiority trial. BMJ Open. 2025, 15, 6E094409. PMID 405507112. https://pubmed.ncbi.nlm.nih.gov/405507112. DOI 10.1136/mjopen 2024-094409. 4. Thakur et al. Indian green pit vipers, a lesser-known snake group of northeast India. Toxicon, Official Journal of the International Society on Toxinology. 2024, 242:107689. PMID 3853147. https://pubmed.ncbi.nlm.nih.gov/3853147. DOI 10.1016/j.toxicon.2024.107689. 5. Carvalho DS et al. Photobiomodulation therapy to treat snake bites caused by Bothrops atrox, a randomized clinical trial. JAMA Internal Medicine. 2024, 184-170-80. PMID 3804890. https://pubmed.ncbi.nlm.nih.gov/3804890. DOI 10.1001/germane-termed.2023.6538. 6. Lamte et al. The 20-minute whole blood clotting test, 20 WBCT, for snakebite coagulopathy. A systematic review and meta-analysis of diagnostic test accuracy. PLOS neglected tropical diseases. 2021, 15, 8E00096557. PMID 343753338. https://pubmed.ncbi.nlm.nih.gov/343753338. DOI 10.1371/journal.pntd.00096557. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.